much for being with us and speaking with the Perry community. We are just so grateful and happy to have you here. And I have so many questions, but if I might just introduce you before we get started. Everyone, this is Dr. Nicole Harkin, MD, FACC, which I learned, I did not know, is a fellow of the American College of Cardiology, a board certified internal medicine doctor, let me say it again. You are board certified in internal medicine, cardiology, echocardiography, am I saying that?
Yeah, you got it.
Get it all in, okay? Nuclear cardiology and clinical lipidology, which means you are a cholesterol doctor, specialist.
Yeah.
Dr. Harkin is now based in San Francisco, where she founded Whole Heart Cardiology, which I'm really excited to learn about, with the mission of providing patient-centered cardiac care, evidence-based nutritional guidance, fantastic, and personalized lifestyle plans for your patients in a modern setting. Welcome again. Thank you so much for joining us. So if you would, Dr. Harkin, you're currently in San Francisco, is that right?
Yes, I am. I am from the West Coast originally. Actually, I'm from Portland, Oregon, but I did all of my training on the East Coast and lived in New York for the last 12 years and was in private practice there and, doing my thing. And then we moved to San Francisco about a year and a half ago. I'm excited to be back West. And that's when I launched Whole Heart Cardiology shortly after getting to San Francisco. I just decided it was time to, practice medicine the way I wanted to and be in charge and really just dedicate my practice to prevention, which has been always my passion, and helping women and men treat high blood pressure, cholesterol, heart disease with a lifestyle first approach.
That is awesome. It's wonderful. It's so welcome to hear. There's so much chatter in the medical community, particularly from other doctors speaking about why isn't there more preventative care, and there's sort of like a lot of frustration, I know, around that. So kudos to you for opening your own practice with that kind of a focus. You're also a mom, is that correct?
I am a mom of 3 littles. So I have a almost 7-year-old son, a 4-year-old son, and a 20-month-old daughter.
Oh my gosh. Wow. You real littles.
I do. Well, we're still in the thick of it.
But
it's fun. Yeah.
And with your own practice, that's super impressive. Okay. We're going to dive in. Sorry, I just got distracted. I was thinking of another question, but I'm just gonna follow suit. Okay, here we go. If you would, what is the relationship between menopause and heart disease, if any?
Yeah, absolutely. So the risk of heart disease in both men and women is the same, in the sense that it is the number 1 cause of death worldwide for both men and women. And so I think that point is really important to just kind of lead with, because I think, unfortunately, as women, all too often we sort of think of the other things like breast cancer and all these other things, which are important, and we need to do our screenings and we need to pay attention to it. But we don't think as much about our heart health. And so it's the number 1 killer, important to recognize. But it's interesting in that we see our risk change over time. And in both men and women, the risk of heart disease goes up as we age. Age is the number 1 risk factor for heart disease, unfortunately, and nothing we can do anything about. Yeah. However, there is this time in our life, menopause, in which our risk of heart disease does grow and increase dramatically. Okay. And it's thought to be due to the withdrawal of estrogen, which is cardioprotective. And so during perimenopause actually is when we see a lot of changes in terms of our vascular age, our cholesterol. So we definitely in menopause see cholesterol go up, in particular our LDL cholesterol, which is the bad cholesterol. We also see changes in adiposity, meaning fat distribution and composition. So our body composition changes. And we see decrease in lean muscle mass and an increase in what's called visceral fat, which is the fat that collects in our organs, in our abdomen. And that's the more dangerous kind of fat that's associated with metabolic syndrome. We also see blood pressure changes. Interestingly, in studies in women undergoing menopause and perimenopause, we see that our blood pressure does change, in particular, our nighttime blood pressure. So our blood pressure is supposed to drop at night, and at night in women who are undergoing menopause in kind of the perimenopause state, we see that they don't dip as much as they previously did, which is a risk factor for heart disease. So there's all these different risks that we see that are modulated and become more apparent in women as we go through this natural transition. And so we see that the risk of heart disease it goes up, and at age 65 in women is when we start to really see the increased risk of heart disease.
Okay, wow, that's a lot.
It was a lot. I'm sorry.
No, it's wonderful and critical information. And one of the things well, first of all, it's interesting that sort of all of the systems, if you will, become a little more vulnerable as we age. So that's one thing to think about. I have to say, as much verbiage as is out there, particularly in social media around perimenopause and menopause, I still am always surprised at how little I hear about heart health, which is why we're so excited to be speaking with you today, that it's the #1 cause of death globally among men and women. I didn't know that. I knew it was among women. I didn't know it was global, and it's really critical information. The other thing that stands out to me just immediately what you said is about estrogen being cardiac protective. Is that right?
Yeah.
And about the role of fat. So adipose fat, visceral fat, and the reason that stands out to me in particular is because there's so much dialogue around sort of belly fat and weight gain and the role of estrogen and blood sugar and just the plain old, frustration around aesthetics, right? That we have this attachment to weight and not wanting a lot of weight, but it sounds like sort of focusing attention in terms of heart health on reducing that adipose fat or visceral fat is particularly important.
Yeah, absolutely. I mean, I think you're correct that certainly there is there's a lot embedded when we talk about weight and weight gain and where it's coming from, and it's a big struggle that in particular, unfortunately, from a societal standpoint, that women tend to struggle with this and discuss this and what have you. But I think certainly what has come to light over the last couple of years is that weight can affect us in different ways. And I think just looking at it from that sort of standpoint, from like a heart health standpoint, is that we do want to try to minimize weight gain in the central, what's called central adiposity, which is can be broken down into two different kinds. So the weight that is visceral is the one that's in the organs and the inside. And then there's the subcutaneous fat, which is kind of the kind of fat that you can grab that's around your waist. That's not as critical. So when we talk about body composition changes, what really can impact us in terms of our longevity and all of that is really the fat that can collect around the organs. And so there's different, and that's associated very strongly with something called metabolic syndrome, which is this syndrome in which we see sort of adverse glucose changes like pre-diabetes, sort of some blood pressure changes, your triglycerides going up, your waist circumference going out. And that one is a big one that we do start to see emerge in midlife and is strongly associated with cardiovascular disease.
Okay. Thank you. We'll get back to that. I want to get into that a little more if we can in a little while. You also mentioned nighttime blood pressure, and it made me think of my next question, which is actually about heart palpitations.
Yes.
And so I had it on the list, and then I also was thinking about the fact that I personally experience palpitations at nighttime. So I rarely have anything during the day, but I notice that when I lay down and I'm kind of like, just relaxing in bed, I have this like fluttering thing. So I don't know if the two are attached. And I certainly don't mean to make this about me, but I'm just wondering if you can speak to both of those again.
Yeah, so heart palpitations are a great one, and I'm really glad you brought that up because it is such a common symptom that women experience throughout their lifetime. And so younger women tend to have a lot of palpitations around their menstrual cycle as well. So it's definitely related to natural hormonal changes throughout our lifespan. And so palpitations is another symptom that's quite common in perimenopause. It's thought to be related to that drop in estrogen and those hormonal changes. Unfortunately, like many things related to specifically women, it's very understudied. And so we don't know a lot about it. And in a lot of the studies, it tends to be closely tied into sort of hot flashes. But for many women, those are kind of separate symptoms. Some women do get palpitations with hot flashes, but other women have palpitations that are sort of separate. So, by and large, we think that it's related to a lot of the hormonal changes. And when we say palpitations, it can be very different for different women. So some people get heart racing, some people get sort of an irregular thumping, all of these sorts of things. And oftentimes it can be related to the natural changes in the circadian rhythm that occur in our body throughout the day, where we have different levels of sort of the sympathetic part of our nervous system, which is active, which is the fight or flight, and then the parasympathetic, which is kind of the relaxation. And so that can cause changes in our heart rate. And then we also can see sometimes some extra heartbeats that happen that are typically not dangerous. And, we can see different things like that can come up. So by and large, most palpitations for most people are not necessarily dangerous. They can be troublesome and very, very bothersome. But those should be sort of distinguished from something like an arrhythmia, which is an actual heart issue in which the heart is beating not normally. And if there's any concern for that, obviously definitely seeking medical care and making sure that gets ruled out. And then once something like that gets ruled out, beyond that, it can be, people can focus on different things. I have a lot of patients do what's called a palpitation diary, which is trying to figure out what's a consistent thing that's causing them to occur. Some people are very exquisitely sensitive to caffeine, even the content within dark chocolate, all these different things that can play in. And sometimes we find some lifestyle changes can cause give some relief for sure.
So Dr. Harkin, just to circle back for a second, I just want to understand, many women in the Perry community describe heart palpitations that might sort of, prompt them to go visit the hospital. Obviously you can't treat people here and now, but what can you just sort of say again about arrhythmia and what it is that might actually prompt you to go? And also, if you could, I don't mean to frighten anybody, but I am curious, like, when I know that it can look different for a woman than a man who is experiencing a heart attack. And I also know that women are sort of less inclined or often can tolerate discomfort and pain more, or sort of like quicker to go, I'm fine, I'm fine, I'm fine. So can you just sort of lay those things out as well?
Yeah. So with regards to the palpitations, certainly if you are concerned, you should call your doctor or seek medical care. I mean, it's better to get checked out and everything's fine than not. So that's number one. Definitely things to seek medical care, things that should alert you that something might be going on, would be something like feeling lightheaded, definitely having chest pain or shortness of breath, or otherwise just feeling very unwell with the palpitations. Those are definitely things that you should for sure talk to your doctor about, and urgently. If it's something, and then other women tend to just have like, oh, that was a weird kind of flutter sensation, and that kind of happens every now and then. That's definitely something to bring up to your doctor, but is much more common and somewhat less concerning than some of the symptoms that I mentioned. So if any sort of palpitations that are associated with lightheadedness, chest pain, shortness of breath, those sorts of things, that is increases our concern that perhaps this is a different heart rhythm. So our heart has a natural electrical conduction system within it. It has a pacemaker in it that tells it to beat. And that pacemaker can increase or decrease depending on all these external stimuli. And that's the heart's normal response, and that's responding normally. But then other times the electrical conduction system can act abnormally, and that's a heart arrhythmia, like atrial fibrillation would be one that someone has heard of commonly. And that it needs to be treated much more differently than someone's heart that's just going a little bit faster than normal because they had too much caffeine, or they got stressed out, or their hormones are changing, or what have you.
Okay.
So that's the palpitation component to it. And then in terms of whether or not someone with women and heart attacks, certainly women can present differently, although I will say that the most common presenting symptom of a heart attack in both men and women is chest pain.
Okay.
That said, women can have a different type of a chest pain, and where it can just kind of feel more discomfort or burning or uncomfortable. It can occur in the neck area or kind of an arm. Most commonly, it's sort of centrally located. And then some women sort of just feel more short of breath, or kind of just very unwell feeling, just kind of a general sense of something is wrong.
Okay.
Certainly it's always better to get checked out than not and feel silly. I've had lots of patients to go say, I felt so silly. I was like, no, do not feel silly. I am glad you made sure everything was fine. Because women tend to present later in their heart attacks than men do. So certainly if there's a concern, I'd rather you be an advocate for yourself and go check it out.
Is there a reason for that? Is it more of a behavioral thing, or is there a physiological thing?
We just tend to ignore things more. We're looking out for everybody else, or we don't think that, I mean, it's still, as you said, very under-recognized that heart attacks can and do occur in women. And so women are like, oh, that's not what that is.
Right.
And so we do present later in the course of our heart attack.
Okay, awesome. Thank you. At what age, Dr. Harkin, do you start to see women requiring cardiology care? And also, sorry to piggyback off that, are there any common trends like high blood pressure or elevated cholesterol? You mentioned those earlier, that impact this as well.
Yes, absolutely. So the risk factors for both men and women, the strongest risk factors for heart disease are high blood pressure, high cholesterol, diabetes or pre-diabetes, having excess weight, physical inactivity, cigarette smoking, poor nutrition, all of those things that we've come to recognize. Those are kind of the biggest risk factors, and then family history, biggest risk factors for heart disease. And so, in the course of one's life, it's preferable to try to deal with those risk factors earlier on rather than later. So in my care, I tend to see actually a lot of younger people, people in their 30s and their 40s, even in their 20s, who are trying to tackle some of these issues before they have the heart attack or the stroke. So there's no wrong time to enter care with particularly a preventive cardiologist, especially if you have a family history. And in fact, and then touching on kind of some of the unique risk factors to women. Definitely some of the biggest ones are pregnancy related risk factors. So what's not as well recognized is there's certain pregnancy complications, particularly something called preeclampsia, which is having very dangerously high blood pressure during pregnancy, that actually, people focus on obviously the emergent issue because it is life-threatening for mom and baby, and we need to deal with that. But then what a lot of people don't realize is having that episode actually dramatically increases a woman's risk of heart disease later in life.
Wow.
And so I see many women who have had a history of preeclampsia or other pregnancy related complications. And it's important, to then after the fact, at some point circle back and start to look at, okay, what are the things that we can optimize to reduce our risk going forward? So that's a big one for women. We also are more likely to have autoimmune conditions and rheumatologic, so lupus, things like that. Those increase our risk of heart disease. And then just circling back to menopause, the earlier we have menopause, so early menopause before the age of 40, or premature rather, and then early menopause before the age of 45, because of that withdrawal of estrogen earlier on, women that have premature and early menopause do have a higher risk of heart disease later in life as well. So there's all of these things that happen earlier in our life that increase our risk for heart disease. That it's important to kind of really pay attention to, because even though we don't typically see heart disease in women until they're 65 or older, heart disease is a systemic issue, and it's a lifelong issue that's been building up for decades and decades and decades. So even though women don't tend to have heart attacks until they're later, there's all of these things that we can be doing something about much earlier in life.
This is fascinating. And so I'm so happy to be talking to you. This is such important information, and I think I'm so, glad that you have patients. I hope they're by and large and well, but that you have patients who are younger and learning this stuff at a younger age, because it really is sort of cumulative, I think is what you're saying. And there are things that happen, but there's also sort of lifestyle behaviors that you can sort of buffer yourself with, which is amazing. And I think, I don't know, you would correct me if I'm wrong, but it seems like it's not too late either. So if you're in perimenopause or menopause and you may be primed for things like maybe you have a genetic predisposition for heart disease or you have an autoimmune condition, there are still things that you can do, which we can get into later, to sort of continue to buffer yourself or shore yourself up, protect yourself against episodes later in life. Okay.
Absolutely. It's never too late. And yes, why I prefer that we start working on these things when we're in our 20s and 30s. Definitely in our 50s and 60s, there's lots of people that really start to kind of try to make some changes, and optimize some of these things. And the sooner the better. Yeah. But there is all types of people that make interventions at all points in their life for sure.
Okay. So with that, one of the questions I had, and I'm thinking about it's factoring into what we're talking about, is sleep. Is sleep an issue in terms of sort of, I guess, weakening the heart or impacting the heart negatively? And would it be one of these things to sort of really give attention to?
Absolutely. So there's a lot of different lifestyle factors that we can and should focus on to reduce our risk of heart disease. And sleep is certainly one of them. Okay. So inadequate amount as well as quality of sleep is an important risk factor for heart disease. So on average, we should be trying to aim for, and I'm sure a lot of people have heard this, the 7 to 8 hours of sleep a night. But getting a lot less than that is associated with an increased risk of heart disease. And when we go to sleep at night, that's the time when our body can repair itself and rest and recuperate. And you know, it's important that we have those periods of our day where we have less stress because we're sleeping and repairing. So those sort of circadian rhythms and those natural cycles of hormones and sympathetic versus parasympathetic activity, those are all really important functions. And intertwined in that is also the quality of sleep that we're getting. So it's not just enough that we're in bed and asleep for 7 to 8 hours, but also having good, uninterrupted, high quality sleep is important as well. So certainly probably one of the biggest sleep disorders that we see, obstructive sleep apnea, is a huge risk factor for heart disease. And in case any of the listeners haven't heard of that, obstructive sleep apnea is essentially when the airways collapse somewhere along the oral pharynx intermittently overnight. And so what's happening is we're getting periods in the night where we're not getting enough oxygen. And that causes your body to like mini awaken, basically. And so all throughout the night, you're having these episodes, and most people don't remember waking up, but your body's waking it up enough so that it gets enough oxygen. And so you just kind of repeat the cycle over and over and over again. And if it's severe, it can really increase your risk of high blood pressure, atrial fibrillation, and heart disease. So that's certainly something important to know about. And the risk of that does go up as we age. The major symptoms of that are things like heavy snoring, excessive daytime sleepiness, or feeling unrefreshed in the morning. And that's because you've been waking up all night, you just don't remember. Sure. A bed partner saying that you are gasping or kind of choking periodically at night. And it's more common in individuals who have a thicker neck or have excess weight. So those are sort of things to look for. And it's pretty easy to get screened for it these days. You used to have to go into like a sleep center and sleep overnight in some room. And now there's a lot of really high quality approved at-home sleep devices. So you can sleep in the comfort of your bed and send it back in, and then a specialized sleep doctor reads it. And then there's different, treatments for it, depending on the severity, that can range anywhere from lifestyle changes, including weight loss, to different dental sleep devices that a specialized dentist can make to keep that airway open, to something like CPAP, which is a positive pressure kind of machine that, while is a little bit more cumbersome, can be like life-altering for some patients.
This is incredible. Thank you. Dr. Harkin, are there routine cardiology tests that all women should be getting once they reach menopause?
Great question. So in general, throughout our life, we should certainly be getting screened regularly by seeing a doctor to check our blood pressure, keep an eye on our cholesterol, all of those sorts of things. I think one of the biggest tests specifically for the heart, depending on age and risk factors, that is increasingly being recognized as something called a coronary artery calcium score. It's called like a CAC for short.
Okay.
Basically, it is a specialized CAT scan. It is a low dose CAT scan of just the heart. And the amount of radiation at this point is about a mammogram. And what it does is it measures the amount of calcium, which is hardened plaque in the arteries of your heart. And it can be something that is, it's not at the point where it's like a colonoscopy and a mammogram that everyone should be getting it, but it is definitely based on risk factors and things like that. Certainly something very appropriate to discuss with your doctor in kind of midlife. And it can be helpful in terms of assessing where your heart is at, and if you would benefit from, cholesterol medications, or, really motivating you to make some major changes in your lifestyle to optimize risk factors. So that's a test that I order frequently in some of my patients to really get a sense of where they're at. And it can be very reassuring if the coronary artery calcium score is 0, that studies have shown that your risk of heart disease in the next 5 years or so is really, really low. So it can also provide reassurance as well.
That's amazing. I had no idea that existed. Okay, so why are women at an increased risk of heart disease? And I'm also wondering if you can speak for a moment about if there exists a risk among Black, Brown, Asian, Latino, Indigenous women as well.
Absolutely. So cardiovascular disease is the #1 killer for everyone globally, as we said, and for women in particular, and for every ethnic race, I believe, in the country and the globe. So definitely in African-American women, Black women, it is the #1 cause of death and morbidity and mortality. And we see this, we see in some populations increased risk of blood pressure and other risk factors for heart disease, and which is increasingly being recognized that it is because of, socioeconomic determinants of health,
right,
and the implicit issues within our medical system, access to care, all of these things that we're seeing.
Okay, thank you.
Yeah.
I'm sorry, did I lose you? Are you there?
Yes.
Can you hear me? Okay. It got so silent. It was weird. I'm so sorry. Okay.
No, I think it did cut out for a second.
It did, right? Okay.
Yeah, it was really weird.
Okay. Could you get into nutrition and heart health?
My favorite.
I knew it was going to be. So just let me go on just for the question, just for a second, because I want to make sure I get it all out. Why and how does food factor in? And what should women over 40, assuming you are not premenopausal, be focusing on consuming more or less of, or I should say more and less of?
Okay. So nutrition is one of those topics that I could probably talk for hours about. But I would say, yes, that's what I wanted to know.
Yeah,
okay.
right.
We're answering some questions you want to know. Hopefully this isn't the first thing we've answered that we wanted to know, but I'm glad that people are excited about this. So nutrition in general is probably one of the levers that we can pull that can really impact our risk of heart disease dramatically throughout our lifespan, and is something that everyone can and should ideally do. It probably affects, genetics are important, but a lot of heart disease is preventable. And I feel like so much of this so far has been doom and gloom. Like I feel like almost all of my answers.
It's so funny you say that, but you know what my questions are too, and it's scary. And when you think about things that feel out of your control, it can feel like, oh my God. But I think the information is so powerful, right? And it's everything that we need. So we have to sort of understand all of it. And this is super hopeful, this part.
Okay, good. I hope this is where I'd like, cause I feel like like from all of these different questions, I'm like, oh my gosh, I'm feeling like I'm just scaring everyone. But there are a lot of things that we can't change. And so that can be very scary, but this is something that we can change and we can focus on. Everyone can do this. So nutrition is one of the biggest things that we can really focus on. And, I wouldn't say it necessarily changes dramatically over the basic tenets don't change dramatically over our lifespan. But certainly focusing on trying to get more plant foods where possible. So fruits, vegetables, whole grains, legumes, nuts, and seeds. We now have just like a robust amount of data that really shows that that consuming a dietary pattern that's heavy in those things and not emphasizing as much animal products, processed and packaged foods, desserts, all of those things, is really can lead to improved heart health outcomes. And just to kind of further add to the fact that lifestyle is important, we've shown that there's been studies that have looked at individuals who are deemed to be high risk because of their genetics. And even in those individuals, adhering to healthy lifestyle habits, not smoking, trying to maintain a normal weight, being active, and eating a healthy diet can reduce their risk, is associated with a reduced risk of heart disease by 50%. So even in people with a really, strong history, family history. So this, and it's been shown in, studies have looked at diverse populations across the globe. So both men and women, races, ethnicities, ages. I mean, so this is something that can impact everybody and things that we can do. It is not to say it's easy. It is hard and it takes a lot of work.
No, for sure.
But we see that it can really impact blood pressure, weight, cholesterol, glucose control, all of these things. And really what it comes down to is less saturated fat, a lot more fiber, particularly soluble fiber, vitamins, antioxidants, phytonutrients, all those things that come in plants that you just can't get from a bag of chips.
That is awesome. Okay. To piggyback off of that, if you would speak about fasting, and the reason I'm so interested in fasting is in part because it's so popular, intermittent fasting, particularly among perimenopausal and menopausal women. And I'm just wondering, I guess, is it specific to heart health, or is it really about utilizing a tool that helps you lose weight, which then supports heart health, if that makes sense?
It's a really good question, and I wish I had a better answer for you, but the science is very much in the infancy. So a lot of the studies, I know intermittent fasting is very popular. I've had a lot of patients, and as you say, a lot of women who are sort of perimenopause, who've noticed some of these weight changes, use it to really good effect. So I think if it works for you, that's great. As to the science behind it, a lot of what we know is based on animal studies, which is never that. It is hypothesis inducing, meaning we can kind of be like, oh, this is interesting. But really we need a lot more human data before we can say anything definitive. There's been definitely some shorter, so we have no long-term human studies to show that it reduces cardiovascular risk. We do have some short-term studies that show that women and men can improve sort of some body composition, glucose intolerance, blood pressure, some of those things. I think what I end up saying to a lot of my patients is, I think certainly this concept of circadian fasting is important, meaning we're not eating, 18 hours of the day, but really trying to eat as much as possible, kind of when the sun's up, and trying to have sort of a shorter window of eating. That I think so there's some good data behind, and then but certainly what we eat, I think, will always be a little bit more important than how we eat and when we eat.
Yes. Okay. Awesome. Thank you for that. I appreciate that honest answer, really.
I think it's really important to acknowledge the limitations of our knowledge. Science is always learning more. And so I think it's good to know where we're at, what we know, what we don't know. Hopefully in a couple of years, if we have this conversation, I'll be able to give you a more detailed, thorough answer. But again, it's one of those things that, as long as you're being safe about it, is not harmful. And so, you know, some people have found that it can be helpful for them to have more specific prescribed times of when they're eating so that they're not overeating. And I think that that's fine. Other people find it less helpful because then they're starving by lunch and then they overeat. So I think it's a lot about working, you know, finding someone that you can work with to help you work through these things, as to what's going to be helpful for you. We're all different, you know, there's no one size fits all.
And to be focusing on more plants, fruits and vegetables, whole grains, less animal fat, and vitamins, antioxidants. What am I missing? Healthy fat. Okay.
Got it.
Okay. Exercise.
Yes.
Tell us what we should be really trying to get in during the course of a week, and how much. And you know what? I just thought of this, but I'm really curious about this. So just because, you know, we are so sort of like trend focused, and HIIT exercises would be another one that I think is like really trendy right now. And personally, I love the idea of like a 10-minute hard workout and, you know, you're done. But I don't know how many people really go that hard, even for 10 minutes, to make a difference. And so I was thinking about like HIIT versus, you know, a 20-minute jog, or does it really just not matter? You know, whatever sort of gets you out of breath. Is that a thing? Is sweating a thing? What should we be thinking about?
Yeah. So exercise is great. I think that behind nutrition is one of the other big levers that we can pull. So the American Heart Association recommends 150 minutes of moderate intensity exercise a week. And you can just kind of break that up into however you want to. So some people like to do 20 minutes, 40, whatever it is throughout the week, trying to get that. And that's just based on epidemiologic data showing that after, you know, there is a set point in which we see a certain amount of exercise per week as really having the lowest risk associated with heart disease. The benefit continues to go up until about 300 minutes a week. And then beyond that, we don't see much benefit at all. So, and it can be, and moderate intensity exercise are things like, you know, a jog and, you know, tennis, like that kind of stuff. If you want, and then there's like the vigorous type of activity, which they say, they say that the equivalent amount, I do not know why that word was so hard for me. The equivalent amount of 150 minutes of moderate intensity is about 75 minutes of vigorous activity. So you can kind of do either or, mix match. There is some small, and it's interesting that you wanted to bring up some of these trends, because, you know, it feels like sometimes the science is like a little bit behind where these trends are, and then we study them. So there is some data with HIIT that it definitely could be superior in some ways. I can't remember. There was a couple small studies, and they looked at different, I think, body composition and different risk factors and things like that. If it's something that you enjoy and it gets you excited to do it and you're going to do it, like, go for it.
Yes.
But if it's not something you like, do I think you have to do it? Like, no. But what I would say is, beyond kind of doing that aerobic activity, it's also important to try to get in some strength and resistance training, because there is some data to show that is, especially in women, particularly if you're talking about some of these body composition changes, resistance and strength training, it may be superior to sort of typical sort of aerobic activity for that particular issue. And so building up some of that lean muscle, particularly as we age, for our bone health. I mean, there's all these good reasons. is really important and traditionally been kind of neglected by women, I think. And so definitely trying to focus on getting 1 or 2 sessions of kind of a resistance strength training in there as well can be really helpful.
Okay. I hope this won't make you nervous, but I'm just so curious. I know it's such
hit me. Just ask me.
How do you eat? And you're a doctor. Like, I know you're busy and your hours are tough, but like, what does your kitchen look like? What does your activity look like? I guess that's my question.
That's totally fair.
Okay.
I should practice what I preach, right?
Kitchen tour. Well,
kitchen tour, I love it.
I mean, I think, no, I don't mean to suggest that, but I do think, like, knowing so much, I'm just, I'm curious how it sort of is internalized and what you can share with us about how you approach it.
I'm totally happy to. And we can, next session can be the kitchen tour. I can invite you.
Maria Luisa says it's all my idea. It's all my pressure.
Love it. You crack me up. So I'm plant-based. So I eat almost exclusively plants. I guess a typical day in the life. I eat oatmeal like almost every day.
Okay.
I love oatmeal in the morning. Yes. And I add in a little banana and some chia seeds and some flax seeds and some cinnamon. That's my go-to breakfast with soy milk on top. And then I typically will do like a big old salad for lunch. It has like any variety of random vegetables I have in my fridge, usually either beans and or tofu for protein.
Okay.
And then dinner is like, it just totally depends. I do lots of tacos, I would say, is a big one, probably once a week with veggie tacos. I do a lot of like bean pastas with tons of veggies. I mean, you name it. Like I've been doing different wraps and things like that. So I tend to eat pretty much all plants.
Okay.
It is not to say that I don't have processed foods on occasion. I am not perfect. And I think it's also really important that we're so hard on ourselves. And I feel like, one meal does not define you, nor ever will. And I think so many times my patients freak out because they've had, and then they spiral and then they're like, oh, the day's just done. I'm just gonna eat, like, all day. So just trying to be like, you know what? I'm craving this. I'm going to have it. And then I'm going to move on with my life. And then I'm going to get back to like my normally scheduled program for the next meal. So there's different, so I hesitate to like say too much of what I eat because I do not want to come off as if I'm eating perfectly.
No, not at all. I really just it occurred to me, like what might be, what do you really focus on for yourself and your family and just
my family, right?
Yeah.
And my kids do eat some, they eat dairy, and my husband still has some meat here and there. So they have that. And I think for lots of people, if they're trying to eat more plants and maybe other members in their family aren't, there's so many different things that you can do that can be like a mix and match, like grain bowl. I do that a lot. And if, you can have meat on the side, and if someone wants to add meat, they can, and then the other people can add tofu. So there's all these different types of mix and match things that you can do throughout the week that really do not require multiple meal preps and really can kind of appeal to all of the palates. And there's so much inspiration now online. We're just so lucky. There's all these like recipe creators. And I mean, there's just a plethora of like delicious, healthy food.
Absolutely.
Again, not to say that it makes it easy.
No, but actually your suggestion is really a helpful one, that there is a way to sort of address everyone in the house. Cause I think that's also a big deal for people that, you don't want 3 kitchens going, and that's really helpful. Thank you for indulging me on that. Okay. What is the one thing that you constantly find yourself repeating to your female patients? Is there anything that you just consistently find yourself trying to drive home?
That's a good one. I think the number one thing is that I bring up to women is I think some of what we've talked about, which is that heart disease can and does happen, and in women, we are at risk. We do need to be our own advocates. We need to be able to speak up if we're feeling something. Like, women historically get dismissed, and like going back to the palpitations conversation, I have definitely had women who've come in to see me who have complained about palpitations for years, and lo and behold, they actually have a real arrhythmia, and everyone was just like, "Oh, it's stress."
Yeah.
So, and not to scare people, most people
No.
it's nothing, but if you feel like something is off, or and you don't feel heard, then find someone else who will listen. And I think that that's really important, because as I said, like, women, we are underrepresented in clinical trials. We are, there's 12% of us are cardiologists. So we get dismissed a lot by the medical community, who think our complaints are just, whatever. And we're undertreated. So women who have heart attacks, there's been studies, and we're less likely to get the medicines that we're supposed to be getting. And so I think, unfortunately, because it's still a man's disease, and it's getting better. I don't want to be all doom and gloom. I think that it's increasingly being recognized, but unfortunately, I think women do still need to be able to be their own advocates. And we need to advocate for our sisters and our other women in our lives as well. Like, no, go get that checked out. You really should,
Yeah.
And we're so often kind of the caregivers in our families. And we do need to be able to kind of pay attention to our own stuff too, and make sure we're looking out for ourselves. I mean, I do this too, right? Like, the berries, I'll like save for the kids. I'm like, no, we need to eat.
You need to eat them too.
Not just crust on the sandwich,
Yes.
So I think for women, I know we're typically often the caretakers, but just trying to really make sure that we prioritize ourselves as well, whether that's eating healthy, or getting our blood pressure checked and seeing the doctor, or making sure that people don't ignore us when we say we're having, chest symptoms.
I just have a couple more questions before I let you go, if that's okay. I will be taking this.
I do have a patient appointment in 6 minutes. So.
Oh my gosh. Okay. I'm wrapping this up then. Forget my extra question.
No. That's one more. It's telemedicine. The beauty of telemedicine.
Okay. I just, I wondered if you could weigh in on stress, and how much that sort of impacts heart health. We talked about, smoking and genetics and a sedentary lifestyle, sort of nutritional deficiencies, but I'm just curious about stress and stress mitigation. And finally, and you really just sort of touched on this already, but is there anything that you wish that all women knew about their cardiac health?
Okay. So stress, absolutely an emerging risk factor. I'm really glad you brought that up, because we didn't touch on it. But certainly something that has been amplified and just like, this last year and a half has been just an unbelievable amount of stress for everybody. And so certainly recognizing stress within our bodies, it definitely does increase chronic stress, as well as discrete acute stress. So traumatic episodes, PTSD, things like that can increase our risk of stress, of heart disease. And so if we do have chronic stress in our life, again, recognizing it, we do have a decent amount of data. It's not robust, but enough to show that things like meditation and other sort of self sort of calming techniques can really be helpful in terms of potentially mitigating our risk of the impacts that stress can have because of inflammation, cortisol. The sympathetic response we've been discussing, all of these things. If we're under stress chronically, when those things are chronically elevated, you see that risk of heightened.
We'll have you back another time to talk more about that, because that's really important.
That's a whole nother topic, right? I feel like every question you've asked me could be a whole
to
topic.
go on. I know. We're absolutely going to have you back, but is there anything you would just sort of leave us midlife women with, sort of to know about our cardiac health?
Look after yourselves, look after your families, and certainly, again, I want this to be as uplifting as possible. Yes, heart disease is something that matters, that impacts all of us, potentially, in a very dramatic way. And so, but there are, it's estimated that 80% of heart disease is preventable. And so we can, again, not to say that it is easy, but there are things that we are in control of, that we can do, that we can change, to reduce our risk of heart disease going forward.
Okay, that I will leave you with that. That is an incredibly uplifting message. And thank you, Maria Luisa. Thank you so much, Dr. Harkin. This is like, I want to like scoop you up and drop you in the Perry community and make you stay there forever, talking to us and teaching us. This was just an incredible hour. I can't thank you enough. And we will absolutely make plans to speak again in the new year.
Great. I hope so. This was really lovely. I'd love to come back anytime. We can talk about all these other topics in depth.
Terrific. Thank you so much. Thank you for squeezing us in this hour, and
Absolutely.
have a good rest of your day.
So lovely meeting you. You're like the best interviewer I've ever had, I think.
I'm so glad. Thank you. I love meeting you and speaking with you and learning from you. And I can't wait to do it again. This has just been a fantastic hour.
I hope people learn things, and
God, yes. Thank you. Thank you, Dr. Harkin. Be well.
Bye, guys. Thanks.
Bye, everybody. Thank you.